Good morning, everyone, and welcome to Mailman Center Grand Rounds. My name is Jeff Frost. I'm the Associate Director of the Mailman Center, and I'm a pediatrician here at UM. I want to welcome our resident applicant class. Thank you guys for being here. It's great to have you. As usual, as most of you know, you are the initial early arrivers. There'll be another wave that comes afterwards, so I'm going to do a 20-minute introduction, if that's okay with you, Tom.
Sounds good.
Give a chance for people to get here. Dr. Tommy Schechtman is my good friend and colleague. I'm going to tell you sort of the formal stuff first, and then why I think his talk is so important and why we made this we have two main Grand Rounds Mailman Center talks a year, and Tommy's one of them. So Dr. Schechtman's a pediatrician in private practice. He's the founding partner of Pediatric Partners in Palm Beach County. He's from the University of Texas Medical Branch, which he went to medical school, and Texas Children's Hospital is where he did his residency training. He also has a master's degree in public health from the University of Texas. He's past president of the Florida chapter of the American Academy of Pediatrics. And I would just pause there for a second to say, during his 2-year tenure, Tommy did something that was considered totally impossible. And that is, there was basically Medicaid in many states pays such a low rate that it's an access to care issue. And so 15 years or so ago, the Florida chapter and a number of families brought a lawsuit against the state of Florida saying Medicaid rates are so low that families don't have access. And this 10-year legal battle really was unfortunate in the way that it sort of interrupted the way pediatricians and federal and state government interacted. So it got to the point where we really couldn't talk to each other anymore. And pediatricians had a relatively small voice in our state. And Tommy managed to repair that. He managed to pull all the sides back together and get people talking to each other. And we owe him a great debt of gratitude, even if not everyone thanks him all the time for that. As a pediatrician, he focuses on taking care of children. He specializes in behavioral development and mental health services, and that's the main reason why Tom is here today. He's the first in the state, right, in Florida, to have NCQA Level 3 recognition as a patient-centered medical home, and has been awarded the NGMA Superior Performance for Successful Medical Groups. He's medical consultant for the Palm Beach County school system. So for all the medical issues that come up at the school system level, Tommy is their consultant, the person who goes to it. He and I are board members together in the Florida Healthy Kids Corporation, so that's Title 21 insurance. He was honored as the Palm Beach County Medical Society's 2016 Physician Hero of the Year, and most recently the CDC presented him the 2017 Childhood Immunization Champion Award for the state of Florida. So you're starting to get the picture, whether it's mental health, immunization, school issues, political issues across Florida. Tommy is doing everything. He's clearly a dedicated advocate. He's worked on gun violence, a whole bunch of other issues. One of the reasons why I really wanted Tommy to come here today is there has been this sense for the last 20 years, at least, that pediatric primary care and physical care of kids and pediatric mental health really should be done together. And that the way we've separated them out through our health insurance and our providers doesn't make any sense. Major morbidity today for children who are outside the hospital, it's all about development and behavior. And most families really want to have most of their care done in a single site. And Tommy's done extraordinary work integrating mental health, developmental issues, and behavioral health into his primary care pediatric practice. So this is something that people are asking us to do all the time, and over the last couple of decades, Tommy's actually really done it. So please join me in welcoming Dr. Schechtman.
Good morning, everybody. Thank you, Jeff. Just so everybody here knows, you have an incredible resource in person who is leading the way in the state and also trying to reform how we take care of children, both in the private and public sector. So, Jeff, thank you for all your work. So what we're going to spend some time this morning is really talking about what Jeff said, which is how do we incorporate, co-locate both mental health services and primary care. And in our case, we're talking about pediatrics. So before we start, we all need to remember that our jobs as physicians, as caregivers, as psychologists, as social workers, as therapists, is we are there to help make a difference in our patients, our children, and our families' lives. And we need to do it with joy and with a smile, and we can accomplish something. And one of the reasons that I think, as you'll hear throughout the talk, that I have been sort of attracted to working with mental health is the fact that there's so much reward and satisfaction. Our families are looking and seeking help. They're desperate often, And although you do very little, and the main thing you do, and everybody in this room knows that, is you listen and you listen and you listen. And just by listening to the patient, by listening to the family, you have done an amazing thing. So for all those who are in this room that don't believe they don't know enough about psychiatry, psychology, mental health, you do. You just need to listen, and that's what we do as providers. I'll just look at there. I'll skip the learning objectives because I'm not very good when it comes to academics. So just real quickly, a lot of you know these statistics, but I think it's really important to recognize the impact of mental health in this country and in children. And certainly the national statistics, and we're going to look at Florida, and then we're going to look at Pediatric Partners, is that 21%, 1 in 5 children, have a diagnosable mental health disorder. Another 15, 16% have mental health issues that are not diagnosed or not diagnosable, but certainly have mental health issues. Again, access to care is concerned, only 1 out of 5 of those children, so only about 5% of children receive the treatment that they need for their illness. Again, we need to recognize that 2 out of 3 children have experienced trauma at some point in their lives. The fact is that when you look at a primary care practice, almost a quarter of those people in your practice will have suffered from PTSD. But the most important message is the one that's yellow highlighted, and that is that as pediatricians, we are seeing an alarming rise of the number of children presenting to us in our offices with mental health issues. That's probably a discussion for another day of understanding why that is, and obviously a lot of theories, but to my knowledge, no one really totally can put their finger on why we're seeing so much more, but we are. And one of the things, again, from somebody who has been around for decades, is that, I have seen in my lifetime already a transformation of what we see in primary care. When I started practicing in the 80s, certainly even then, we still had most of what we were concerned about as pediatricians was infectious disease. We certainly had, at that point, many children dying from meningitis, other illnesses. But because of the advent of all the vaccines that we have, that's become a really very small sliver, which is a great thing. But again, as we'll talk about the business aspect of this whole concept of mental health, behavioral health, it's really what is coming to the forefront. And I think that everybody needs to be able to start learning to do this if you want a future in pediatrics. Florida, again, just sort of scoping it down from the nation. We've seen that almost 40% of children in this state have suffered from one ACE, adverse childhood experience. Over 50%, 55% of children in Florida grow up in poverty. Again, another discussion for another ground rounds on the impact of poverty on everything and outcomes. And we know that children who grow up in poverty have worse outcomes as far as health, as far as success in life, but it's all a big impact. And it just blows my mind that so many children in the state of Florida are growing up in poverty. And again, most importantly, we talk about our role as physicians and caretakers. Only 1 in 5 children have appropriate developmental screening in the state of Florida. And so again, another area that we need a lot of work in. So this is Pediatric Partners. This is essentially looking at the past 3 years of distinct, unique patients that come to our practice. And basically, you can see that 20% of children that have present to Pediatric Partners, and I'll describe Pediatric Partners a little bit more later, but the fact is that 1 out of 5 children have a diagnosis of mental health. Lots of issues. There's statisticians in here, other epidemiologists. When I tried to break down this, it's very difficult to get some of these records out of the EHR and how people code and everything else. But it was amazing to me that this number came right at the same number as we see in national averages. And then when we break that down, 82% of that 20% were psychological diagnoses, and the other 18% were developmental. So again, I think that we need to recognize the importance of working together with our mental health colleagues, and we'll talk about the importance of which we have Dr. Raquel Anderson, who you'll hear from a little bit later, is our psychologist who's in our offices. Lots of advantages to that. But again, as pediatricians, as all primary care physicians, we see, primary care physicians write more of the psychotropic medications than do psychiatrists. And most patients present to the primary care office before they present to any other services. And then obviously, as everybody in here knows, there's difficulty in access to care, especially when it comes to mental health. So we as primary care physicians need to be able to step up and be able to provide these services, in my opinion, for our patients. And so I think that, we need to make sure that we continue to have communication. One of the benefits of having someone co-located, embedded, I'm not sure what the politically correct term should be, but having, again, in our office, as Jeff mentioned, we have a psychologist, we have a social worker, is the ability to speak. So, one of the things that I certainly am fine and deal with a lot of psychologists in the community, but communication is difficult. So those psychology interns here, residents or fellows, or whomever, it's really important to have connection with your primary care physicians, have that conversation, because I think we need to collaborate. It's obviously easier when someone's right there in the office or in the building, but again, I think we can't lose sight of the fact that the importance of being able to talk and collaborate. And patients, again, one of the things that they like about our practice, and again, it goes back to patient satisfaction and customer service, if you will, they like the fact that everything is in one office. They feel more comfortable. It minimizes the stigma of having to go somewhere to see a psychologist, a mental health professional. There shouldn't be a stigma, and that's, but obviously we live in a world that there is a huge stigma for that. So, the public health concerns here, and again, as Jeff said, I have a public health background, is the fact that we know that with appropriate intervention, we can provide better quality of care, and we're going to lower the cost of care. And I think as a public health issue, mental health needs to be addressed as such. And we very often in this country, like so many things we don't address as public health, I think it's time that we do this. We need to be able to provide those services. And I think that, as almost everybody here probably has an understanding of, is that we're going to lower the medical costs and we're going to provide better care. If, instead of everybody that has a headache doesn't get an MRI, and you sit and listen to the patient, as I said before, and just listen, never mind just getting into the issue of getting them into therapy, but listening often can then maybe avoid the need for that MRI. Again, an important point, I think what all the previous slides have really underscored is that the diagnosis of mental health is really, truly underreported, underdiagnosed. And I think that we also, one of the important things we need to do in primary care is start making those diagnoses. So, it's all about recognition, coding, speaking to the patients, putting it into a chart, because like any other problem, until we have data, until we have information to say how pervasive it is, we are never going to be able to solve this problem. Because without data showing how widespread and what impact it is, we're not going to get the funding, and funding is what we need so badly in mental health. I speak, again, we gave the statistics, the epidemiology, but when I often speak to other colleagues and physicians, I think almost 80–85% of every patient I walk into has some kind of emotional, psychological, behavioral, parenting, mental health issue that we need to deal with, even though they're coming in for an ear infection or whatever they may be presenting with. So, you quickly, as a pediatrician, you walk in the room, and usually within, maybe 30 seconds, but certainly within a few minutes, you know whether or not you have a gravely ill, physically ill child. But then when you listen to everything else, the psychological component plays a role. So again, it's an important part of what we do is to be looking at that and making sure we pay attention to it. And on the flip side of that is the fact that, and we'll have some, if we have time, some patient cases that when patients do come in for mental health issues, you have to also always be cognitive and aware that there may be an underlying physical problem. So I think it goes both ways. So again, we've talked about the fact that we have very poor health outcomes in this country and very high costs of care. And I think this is one way we can try to improve it. So I think that, just to stress real quickly once again, the fact is that the reason we tried to put it into our office are for the reasons listed up here. It's more family focused, it's more convenient, the patients like it. They like the fact they're going to an office that they're comfortable with, they're familiar with, the waiting room's the same. And the fact is that they trust their pediatrician, and most patients trust their pediatrician as the most trusted source. So talking to that pediatrician, you as the pediatrician, trying to get that patient to understand and recognize what's going on is very important. The seamless care, again, it's very important that we're not just referring patients out. Too much of that's happening not only in pediatrics, internal medicine, family practice. Everything is just turfed out, and we're not doing our role as primary care, as a patient-centered medical home, to take care of that patient if we just keep referring and bouncing patients all around. So I think, again, something, and we have given that up as a pediatrician in my soapbox here, and Dr. Hirschhorn knows this, and he preaches this as well, is that we have given up everything in pediatrics. We don't go to the hospitals anymore. We don't go to deliveries anymore. We don't even take care of sort of moderate cases of asthma. And we need to grab something back, because it can't be. We're not going to be in the new world of healthcare. We're not going to be taking care of snotty noses. There's going to be other ways of taking care of that and doing well child visits. And this is an area in which you can become unique, because for whatever reasons, no one else wants to touch mental health. So I think it is an area, a niche that we as pediatricians can sort of grab hold of. So let me, Halloween's coming, and this is our office, our pediatric practice, and I just wanted to give a quick synopsis of our practice so everybody has a better idea. We are a general pediatric practice, as earlier slides showed, that the majority of our patients are general pediatrics. And we have 3 offices located throughout Palm Beach County. We've been in practice, our practice has been around for about 20 years, and we have 12 providers in the office. But again, it is not just a specialty practice, it's not just developmental, it's not just psychological, but we see everything, do everything in our office, and it affords our opportunity to be able to do more of the mental health. But at this point, what I want to do is bring up our behavioral health clinical coordinator, Paola Pereira, who's going to talk to you a little bit about the program that she's helped sort of coalesce and put together within our office, and sort of formalize things, because I'm not very good about formalizing things or details. So anyway, Paola.
Thank you. Good morning, everybody. So when you have a practice that take care of a lot of kids, and they are coming because they're anxious, or because maybe they are on the spectrum, or because they're having behavioral problems, it is not the same pediatric patient, okay? They come agitated, they can be scared, or they're wild sometimes. So what Dr. Schechtman always have all those patients at the practice, but we say we have to sit down and we have to try to do this and better and organize everything, because some of them need a special treatment. So that's what we are doing. How this works is everybody is important at Pediatric Partners. So everybody has a role. We have triage nurses. We have 5 triage nurses, but one of them is our lead, and she is the one who takes care more of our behavioral health patients. I'm the behavioral clinical coordinator. I'm going to explain to you how that works later. We have front desk and medical assistant. Everybody is important here when the patient arrives to our practice. Okay, why? Because the front desk is the person who's going to register the patient, right? And if the patient is having a panic attack, that patient has to be in the room before 5 minutes. Okay, so she immediately connect with the medical assistant, and the medical assistant has to prepare the room and bring the patient in. Okay, The head lead pediatrician is, of course, Dr. Schechtman, but we have 12 providers. 5 of them work with us in the behavioral health department. We have our psychologist, Dr. Anderson, who's here, and a social worker in the practice that she coordinates all the service for our patients. And after everything is done, we have case management and care coordination. But how that happened, this is our team. And we are on call 24/7. So if Dr. Schechtman has a patient that has to be seen Saturday, 5 p.m., I have to coordinate everything because the patient is going to be at the office at 5 p.m. And if our psychologists have to see the patient between patients because the patient is having a panic attack or the patient is having an emergency or the parents have too many questions, we have to coordinate that. So everything happened in that office. So providers can see the patient. Patients can come for ear infections, but also moms say, well, I talked with the teacher yesterday and he's bouncing on the walls, he cannot stay still, he cannot concentrate, he cannot stay on task. So there, the doctor was seeing the patient for ear infection, but then she made a referral to our behavioral health department because she is probably thinking that the patient could have, you know, some behavioral issues or learning disability or maybe ADHD. Or the patient is coming because fell, and when the doctor is talking with the parents, she notices that the patient is not talking, and the patient is 4 years old and cannot communicate with the parents. And it's the first time that we're seeing the patient, so she made a referral to our service. Or it could be that the patient just called to the call center trying to make an appointment with Dr. Schechtman. Call center have to send patient case. We work with Athena. That is a program that you maybe know what is Athena, but it's a program that we can set up all the cases and everything there. And they send a patient case to me that I'm the behavioral clinical coordinator. And in no more than 48 hours, I have to contact the family and I have to screen the case. Why? Because it's not the same that you are seeing a 3 years old that is probably on the spectrum at 7 p.m. or you are seeing a 3 years old that's probably on the spectrum in the sensory room that we have at 9 a.m. Okay? You have to accommodate the patient and you have to be prepared for the patient. Okay? It is important that 17 years old who is having a panic attack has to be in the room before 5 minutes that the patient arrives. And probably the patient is not having a panic attack in that moment, but probably the patient is really anxious just to see the doctor. So we have to coordinate everything. When I make the call, probably it's 10 minutes, 15 minutes call, but sometimes the parents are desperate and they want to tell me everything in half an hour of the call. So we don't know how long the call is going to be, but we screen the case because we have to accommodate the patient in the best moment at the office with a provider that can give the service to the patient. After we screen the call, I do it myself, or triage nurse can do it. They are prepared for that. We set up an appointment with the treat physician, and after that, after the evaluation, normally our evaluation, we call that consultation, take between 30 minutes, 45 minutes, but sometimes it's 1 hour, 1 hour and a half. So we have a frame of 45-minute, 1 hour consultation. And in that appointment, we talk about everything. And we ask the parents everything. Everything is absolutely important. How the patient is sleeping, who is living in the house, how the patient is going to school, why the patient is not going to school. So absolutely everything is important for us. And after that, we tell the parents what assessment or what questionnaire they have to complete. We have Chatty, we want to talk about that later. Chatty, Smart ESAC, Autism Navigator. So we have programs online that the patients can fill, and we're going to have an idea about, more idea about what's going on. In that appointment, we refer the patient to the psychologist that we have in the office. Or our social worker. Why the social worker? Because the social worker is the one who helped us to get the service for the patient. So let's say that we have a patient that is recently diagnosed with ASD. Of course, we do all the assessment and we have everything done, but those patients need speech therapy, occupational therapy, behavioral therapy. So she helped us. We have a referral coordinator, yes, but referral coordinator just helped to make the referral. But how that happened? Is the insurance covering the ABA? Is this the best place for the patient? Where we can go with this patient is in the area, the service that he needs, so the social worker help us with that. And after that, we have to set up a follow-up appointment with the treatment physician. So normally when they get out of the consultation, that is 45 minutes, 1 hour, they go home with a follow-up appointment, okay? We figured out that appointment that the patient has to be seen next week or tomorrow or in 3 weeks. It depends on the, the decision of the physician. So what we have at the office is, of course, the age-appropriate developmental assessments. We have Chatties that, it's a program that have all the assessment and for the age that is necessary. And also we have Smart ESAC, that is Autism Navigator program here with Miami University. And we explain the parents, and most of the time we do the screening at the office. Our social worker help with that, I help with that, and we do everything at the office, okay? Sometimes that patients with ADHD, we have to ask the teachers. So the good thing about chat is that it's no paper, and we, at the patient register themselves, they complete the assessment, they send an email to the teacher, and the teacher completes. Why? Because the patient normally is 6-8 hours at school, so we need to know the other part too. So that is important too. Is the patient anxious at school too? Is the patient having behavioral problems at school too? So we need to know, and that report comes to our office. We have a person who receives all the results and send it to the lead physician, the one who ordered it. And also our psychologists receive the results, and she checked the results with the patients. We have accommodation for kids with special needs. As you know, being on the spectrum is another word. And they perceive the word in another way that we perceive the word. And they get anxious when they go to the consult. Sometimes they not, but sometimes they do. So we have to accommodate them, and we have to explain to them. We have kids that are neurotypical kids that freaks out because we have to weigh them or because we have to measure them. And as a result of that, we work hard, and we figured out that pictures help a lot. And when they know what is going to happen, they are not that scared, and everything goes better. So we have pictures for them to show them what we're going to do, what they're expecting, okay? We use that for our neurotypical child too, when they are small, when they are scared, when they don't know what's going to happen, because a 4-year-old always go to the practice thinking that they are going to have shots. So we have to explain to them what we're going to do. We have a sensory room. It's bigger than the other rooms. It has good lights and music and beanbag chair and some stool chairs for kids with ADHD that have to move all the time. We have that, and also of course we use the resources, and all the staff at the office know how to use it. The patient is having a panic attack, have to go to the sensory room. We put the lights, down and put music for relaxation. One of the MAs have to be with them until one of the providers go into the room, okay? Counseling and therapy with Dr. Anderson, we have that in place. She's normally with us in the afternoon, but now because we're getting super busy, she's working with us in the morning too. Something that it is super important for us is they need to learn how to express their feelings, and Dr. Anderson used that Disney movie for that, and it helped everybody. We have patients that are coming to the office, and they just go to her room to show them if they are happy, they are unhappy, they are mad, or what they are. We also support schools and programs. This is a really hard part for everybody to understand, but Dr. Schechtman, of course, he is the doctor for the Palbish School, and we work with them. We try to don't fight with them. We work with them. We try to support the patients. School is important. School is a priority in the family, and we need to work with them. We have patients that need accommodation. We have patients that need special accommodations there. We have patients that school say, well, this patient, I don't know if you're familiar with this, but hospital homebound, they say you have to be in a hospital homebound program because you're having panic attacks because you are coming to school. No, Dr. Schechtman doesn't sign a hospital homebound for kids that are having panic attacks because they are going to school. We work with the patient to learn how to cope with the stress to go to school. Dr. Anderson goes to the office at 7:30 to prepare the patient to go to school at 8 a.m. if they need it, but he doesn't sign hospital homebound just because you are anxious about going to school. We teach them how to go to school because they have to socialize, because they have to be in the area, because they have to learn, because they are going to college. So we try and we work with the school, and if he has to be in the phone with the EC coordinator or with the guidance counselor every single lunch, he will do it, okay? But he explained what's going on with the patient and what the patient needs. And of course, we do telehealth. We have a Wally at the office, and why? Because we have a lot of patients that are being successful, and they go college, and they go away, and they are in Washington, California, Orlando, and they cannot come to the office every 3 weeks for med checks or every 3 months for med checks. So we have a lot of rules. Dr. Schechtman is going to talk about that later. But those patients that are away from college, those patients that need appointments regular and they cannot be at the office, when they are stable, he sees those patients by telemedicine. So we set up a call, normally it's at night, and he sits down and talks with the patient for 15, 20 minutes to see how is everything. They have, normally they come to see us Christmas breaks or summer break because they have to be seen at the office 2 or 3 times a year if they are stable. And at the end, everything is how we approach the case, how we help the family. We have to be in the shoes of those families. When you are having a child who is scared, who is depressed, who cannot go to school, who can have a lot of sensory issues, they need support. They need us there. We're practice that listen. That's the more important part. Dr. Schechtman tried to teach everybody that maybe you don't do anything. Maybe you just listen to the parents. Maybe you just listen to the patient, and you just change their life. Okay? Thank you.
Thanks, Paola. So just to sum up, one of the things that this purpose of this slide is really to just show the breadth of diagnoses that we actually handle in our office. So we know that most pediatricians are comfortable maybe with a simple, non-complicated ADHD, maybe some simple anxiety. But again, with time, with experience, with self-education, I think there's an opportunity. And again, certainly once it gets into something that you feel uncomfortable with, referring it out to somebody, a specialist, a behavioral pediatrician, a psychiatrist, is always appropriate. But again, most parents, I mean, it's interesting for lots of reasons. One, because I don't think any child, at least in our area, no child psychiatrist takes insurance. But often they will sometimes go get that second opinion, and almost inevitably they migrate back. So you just sort of need to, oops, what did I do here? There, okay. So we tried to break down a little bit when we talk about the different disorders that we see in our practice. This is again looking at the numbers of the various different psychological diagnoses we see in our practice. And this is the percentage of all patients. And it's interesting to me, I mean, again, my background in public health and data and statistics, I question a lot of this, but it's very interesting, at least when we look at, if you look just to the left of the ADHD, showing that it's 9.5% of our practice, which falls right into what the national, average is. So I found that very interesting. And I think the other purpose of the slide, after I saw it, was to demonstrate to everybody. I mean, sometimes you say, oh my goodness, because everybody thinks we overdiagnose, and then overtreat, whether it's anxiety, ADHD, depression. And it's reassuring, and I think it's a real important thing to say, that what we're seeing in the practice is no different than what we see across the state of Florida, across the country, and so the numbers are really not any different. And the fact is that I think the difference is that we're managing and treating the patients in our practice, not that we see necessarily a different makeup of our population. Again, when we look at the same thing with developmental disorders, and again, national average is, I think for autism is like 1.4%, 1 in 68 or something like that. I think so. The numbers come out very close. And again, I think a lot of these things, certainly the reporting is whether or not, my practice, my doctors are putting down the diagnosis. I mean, one of the things on the previous slide that I found interesting, that insomnia was a very small number, whereas it should be like quadruple, more than quadruple, because everybody has some kind of sleep problem. So there is some certainly bias in this reporting, but it's interesting, it comes out pretty close. This is, again, I think helps argue the business case. And again, we take care of patients because we're caregivers, because we care about patients, but at the end of the day, we have to keep our doors open, our lights on, as everybody knows. Maybe we work for a wonderful university and they take care of everything, but sorry, Gene. But the fact is, you need to do it there too. So this is I found a very incredible slide. So, healthcare, I mean, again, across the board, pediatricians, primary care is seeing a marked decrease in number of patient visits. That can be a good thing, a bad thing. Patients aren't accessing care. Patients are going elsewhere, which is a huge piece of this, going to emergency rooms, urgent care centers, what have you. And so this slide actually, again, I think pleads the case to want to be doing mental health because, again, from a business practical standpoint, over about a 5-year period, the number of patients that came in for behavioral health, mental health, or what we call consults, med checks, went from 8% to almost 15% of our total patient volume. So again, significant dollars of what we can bring in from revenue. It's repeat business. It's again, also a lot of patient satisfaction overall with the practice. So again, we just, this is fine print, but it's our medication management agreement that we have patients sign. It's important. We know that most kids who have ADHD, parents have ADHD, so they often forget their appointments. They don't come in time for medication refills, giving back feedback. So again, this is an agreement, a contract with the patients, with the families, to make sure they understand that. This is becoming much more important now that we have all the guidelines that we have to PDMP and E-Force and look up every patient who gets a controlled substance. So it becomes even more important. We'll spend, if there's interest, we can spend more time on billing and coding. But suffice it to say that yes, we've talked about, Paola we've spoken about that we have a lot of what we'll call soft services, which looked at that, support services, social services. Paola's time as a clinical coordinator, although she's also very good, she actually sees the patients as well. She has an incredible rapport with patients. The fact is that psychologists, the fact is that even though those services are not directly compensated, and you can't charge for those services, although we should be able to. And the fact is that those support services enables me to do my job. I don't have to. I'm free to see more patients, which I guess is a good thing. But the fact is that you have to, in the overall flow, it's the impact on the practice. And I think that, if you want to sustain a practice in today's world, you have to have a niche that makes you unique, that makes patients want to come to your practice. So all those services, at the end of the day, keeps the doors open and lights on and makes us profitable, to be quite frank. Again, one of the questions just talk about, we've touched upon it lightly, is the concern that doctors, pediatricians have about starting to treat and manage psychotropic medications. You know, I remember giving this talk to the Palm Beach Pediatric Society probably 15 years ago, 18 years ago. And, you know, everybody was concerned, you know, number one, that everybody felt that they weren't trained in mental health. You know, they had no training in medical school, residency. And so they were afraid. And they were afraid to ask the question, quite frankly, because they didn't know what to do with the patient when they got the answer. You know, they had no place to refer the patient to, and they didn't feel comfortable doing it themselves. And I think the message here is that we as pediatricians need to be doing it. We can learn this. It's like any other medication. You have to learn about it. If it's a new diabetic medicine, a new cardiac medication, you need to learn about it. And that's what we do as physicians. And I relate a story that when I came out of residency in the mid-1980s, within a couple of years, I was on the executive board, medical executive board for one of the local hospitals. And at that time, what was happening was the advent of laparoscopic surgery. And it's hard for everybody in this room, especially those younger than me, which is probably 95% of you, is the fact that, you know, laparoscopic surgery was brand new. I mean, now everybody thinks it's just, you know, just part of the landscape. And it is. But back then, no one was being trained in it, no surgeon. And we had to do credentialing, and it was really tough because how do you credential somebody in a brand new procedure like that? And these surgeons went, I mean, I remember they went to a 2-day course, maybe a 2.5-day course, just mornings only because they're surgeons and they get to celebrate and party in the afternoon. But, you know, and they came back with a little certificate and said, wow, I'm trained in laparoscopic surgery. And, you know, and they didn't have to do 5 years of surgical residency in laparoscopic. They got it in a weekend. And I said, oh my goodness. If you can learn laparoscopic surgery in 2 days, 2 half-days, why can't we learn how to manage psychotropic medications? I mean, it's just a medication. And you know, I also learned that what attracted to me is, you know, way back when, 20 years ago, there was a residential pediatric facility in our county called Sandy Pines. And we were the medical physicians. And we would go there and take care of any of the medical problems. So you know, we had to do admitting physicals on every patient. We had a, you know, they had a fever, whatever, we saw them. And it's where truly and honestly, and is that you learn that, you know, and they're in there for a month or 2 months. The psychiatrists are, you know, and it's a great opportunity because they're sitting there in a hospital as opposed to being home, but they're managing and trying to figure out the meds. But there's not a science to it. It's not like you take a blood test and say your thyroid level is this level and this is how much Synthroid I need to give you. So you start feeling comfortable. You start practicing slowly. You go slow, and you know you go gradual, and you start learning the medications. You get feedback from your parents and from the patients, and you just sort of start learning. And I think that's something that we have to be open to as physicians. This shows a little bit. There's a fantastic program called REACH Institute. Again, Dr. Hirschhorn, I think, is on their faculty, and they have several. Again, it's a weekend, so you're not giving up much time, but they make us stay into the afternoon. I think that we don't get the afternoons off because we're not surgeons. So, but it's a great opportunity, and it gives you a comfort level just for the basics. You could go take this course and know nothing about psychotropic medications, and you'll come out feeling much more comfortable. They have an ongoing, I think it's for several months, where there's a weekly case study that you present cases, your colleagues present cases. It's a great opportunity. The other thing that's up there in the left-hand corner is an amazing resource. We can certainly have our issues with ACA, and I have had those, but this is an incredible program they do. They put together several different books on psychotropic medications for the use in basically Medicaid patients, because psychotropic medications are a huge cost and they want them to be used appropriately. Every 2 years, they have a gathering of national experts, what they call an expert panel, and sit around the table again for about 2 days and discuss each disease state and what the latest and greatest on medication. And I've been fortunate, representing Florida chapter, to be sitting on that expert panel, and it's a fascinating process. Just as everybody sort of debates what should be the recommendations, what should be the guidelines. So again, those books are really quite helpful for everybody. We've talked about a lot of this, but I think the most important thing is why should you incorporate behavioral health? And for the most part, not only does this improve patient satisfaction, physician satisfaction, and I think physician satisfaction is important. For me, it's intellectually challenging, and it is rewarding. I think that you're doing something new every day. Every patient is different. It helps minimize physician burnout, which you all know is a big, big problem at this point. The business model we've talked about, research opportunities. This is actually Dr. Anderson's dissertation, that her surveys that she looked at our patient population, which just again mimics everything else as far as what she found in the satisfaction of our patients with having the mental health there embedded in the office. Research opportunities, we're doing stuff with the AAP, Chapman Hall, which is at the University of Chicago, University of Miami, was mentioned earlier. Let me just mention this. We're very fortunate. Jeff said we were the first practice for patient-centered medical home. That's not true. We are a patient-centered medical home. Many patient-centered medical homes. We're the first practice that NCQA. Does everybody here know what NCQA is? Patient-centered medical home. No. Okay. So NCQA is a national body that looks at quality of care in hospitals, medical offices, healthcare systems. And they oversee and they grant recognition for doing what they believe are the right standards. And one of the major ones is a patient-centered medical home, and you have to meet a lot of quality standards and outcome standards. They have just now come up with a brand new distinction. I don't know where they come up with these words, but it's a distinction in behavioral health integration. And we are fortunate that we are the first practice of any form, not just pediatrics, but any practice in Florida to achieve this. This is something I think just came out initially in January, and there's only 30 practices in the country with that. So again, it's something, another benefit is that you can use this to market. Again, that's the business aspect. Patients like this, and I think it's important. I think I'm going to stop because I'm running out of time. So maybe I have to do some questions before case studies, or
yeah, let's see if people have questions. We have about 5 minutes.
Yeah, sorry about that. Yes.
Is there a way to inform emergency departments of the services that you provide so that they can connect patients up from their unit to your practice?
Yeah, so that's a good question. Okay, yeah, so I think the question was, how do we interface with local emergency departments so they have access? So I think there's two quick answers to that. Palm Beach County, like I think many counties, have a mobile healthcare crisis, team, if you will, and we have been working interfacing with them, and basically, they have referred us patients directly because again, it's a team that goes out to the school, a team that goes out to the homes and try to interface. Another discussion that I could spend probably 2 hours talking about, and it's one of the case studies. Where is it here? Is the whole horrible rise in Baker Acts, which for those that everybody here know what Baker Act is the involuntary hospitalization for a mental health disorder for someone who's supposedly potentially harmful to oneself or to others, especially out of the schools, children, suspensions. We're trying to work with that closely. 50 in Florida over a 5-year period, I think through something like 2011 through 2016, there's a 49% increase rate, rise in Baker Acts of children, which is 99% of the time unnecessary, inappropriate. This child here, which we don't have time to go into the case, is a child on the spectrum, a 9-year-old child who was in an inclusion school program that the police were called, parents were never called, and the child was Baker Act. I intervened, got him quickly out. He was never actually admitted, so we intervened at the ER. So that the ERs, some of those ERs know about us for sure, whether or not they call on the same day. If you look at up there, same school. So it's a general ed school, plus they have a special program for children on the spectrum. And that morning, this child was taken. I got the emergency call about the child who was on the spectrum being brought to the hospital. Same morning, a mom walks in tears. Her 9-year-old was suspended because the child has ADHD, and the teacher gave him a pencil sharpener. He was very intuitive, took it apart. There was this blade that was obviously a threat to everybody. And the teacher, and he wouldn't give it back to the teacher because he didn't like the teacher. And but as soon as the guidance counselor came in the room, gave it, they suspended him just like that. So again, bad lessons, more trauma. It's an issue that we need to address. Yes, Gene.
My comment and question. So everybody heard all the wonderful things Tommy does. In addition,
I do bad things too.
he managed to convince an insurance company to give us $500,000.
$300,000.
$300,000. So that we could have a consultant that would be available to everybody that's a member of the Florida chapter to help them become a patient-centered medical home. So another kudo to him for accomplishing that. Question for you: in the world of managed care, where mental health is often carved out to specific agencies and others aren't allowed to be paid, how do you get your psychologists paid from those groups?
Right. So, good question. Right now, and this is a area that if I can find the time, I need to work on. Right now, she takes just self-pay basically. We do some Medicaid patients as extended visits, and we were able to manage some of that. But I've had conversations with WellCare, Stay Well, and Blue Cross and United before she left. That medical director was very interested. It's the one that helped us get the $300,000, but she's no longer in the state of Florida. And that's the problem, and same with WellCare, and then they were in active negotiations to get their new Medicaid contracts and CHIP contracts. So I need to reinitiate, but they're very interested in trying to do something. It's just what I would love to try to do something at the University of Miami is that, one of the things I readily admit that I am not good at, which is finding details and keeping statistics and data and trying to look at outcome. And this is a hard area to look at outcomes because and that's what we need to do to try to, the insurance companies are starting to recognize it. WellCare has a psychiatrist, chief psychiatrist, who I've dealt with and I have a good relationship. He's interested, he's intrigued, but we've got to put something together. We've got to figure out how to do outcomes.
Actually, throughout the country, Blue Cross Blue Shield in some areas in the country is actually paying for primary care physicians to go to the REACH program.
Yeah.
So we're actually working here.
That's good. Jeff.
So a couple of comments and then questions, much for Dr. Hughes and Jen. So quick comment on the CMS health plan is moving toward a model that's going to be able to co-locate and pay for behavioral health and mental health in the same place at the same time. And Medicaid sees this in Florida as a model for the future. So hopefully we'll be able to make the payment schemes match up with what families really want. 18 out of our 20 residents are headed into subspecialty care next year. And this has been a rising trend across the country. And so one of the questions too is we focus on primary care today, but a lot of this co-locating also happens in behavioral health settings with our subspecialty folks. And some of them may want to speak up, but Dr. Gibson Jen is our psychologist who's in charge of our training program. We have a large psychology training program. One of the nice things about residency here is that our residents and our psychologists train together in many sites. And I don't know if you want to say something about some of those sites where we have both mental health and physical health sort of co-located already.
Sure. So in our primary care setting, we have more of a prevention model. So we have CompuSet, which is really designated for sort of where they're working with parents and kids, doing developmental, social, emotional screening, and parents' education for the population. Within one of our primary care practices, we have psychology insurance that are located there for consultation liaison services, and then many of our chronic illness clinics, we have psychology insurance and psychology sessions, necrosis, hematology, oncology, diabetes, kind of our behavior patients, and then also training loss as well. But we run into the same issues. The way that we're able to fund a lot of those CNL services are through grant mechanisms or contract mechanisms, and the billing aspect is always a big like, hey, this sounds great, we should do this, but how do we actually pay for this in a long-term viable way?
So I have a quick question, and then we have to wrap up. So, I don't know how many we have in here physicians. Who can tell me what that chemical symbol is? Yes. Excuse me? Yeah, I think so. Anyway, this is a 22-year-old patient taken care of. One day I walked in, saw she came in with this new tattoo on her ankle. I asked her what that was, and she said, it's what saved my life. And I said, cannabis? And she said, no, I'm not very good at chemical symbols either. It's sertraline. Yeah, so she tattooed that onto her. So it's just again patient satisfaction. I was just glad she didn't tattoo Dr. Tommy on her ankle. But, yes.
Would you recommend that we change the model of training in med school and also research, because it's actually a great need, and like you're saying, there's a shift from pathology, from infectious disease to actually mental health and behavioral health. And there's a great, I think, depth of knowledge that I don't know about the training here, but when I was in med school and my residency, I barely even, took part in mental health programs like this. So I think that from the foundation of training, we need to, I think, get this more into that. I don't know if it's something that think about.
Oh, I absolutely agree. I mean, what do we have? Like, out of 36 months, we spent, I don't know, 15 months in NICU. So anyway, one last thing, and I promise I'll finish, but we're going to do it. Yes, you can do it. I got to remind everybody, I have to put my political hat on. Jeff alluded to this. It's really, really, really important that everybody go vote and get your neighbors and friends to vote. We have to change. I mean, the only way we're going to get more services for our children is to change who's sitting in Tallahassee, who's sitting in Washington. So ultimately, funding is the key thing that we need to do. So please go out and vote for children. Thank you.
Thank you.